Chapter 20, Musculoskeletal Injuries. In this podcast, we'll look at general principles for splinting and immobilizing a musculoskeletal injury. We always need to splint an injured extremity before moving a patient unless there's an immediate hazard. If you have to execute an urgent move to keep yourself or the patient safe, that's a decision that must be made. If hypovolemic shock is potential because of that life threat for severe bleeding, make sure that you control the bleeding first. Sometimes aligning the injury will help in terms of controlling bleeding, and then control the bleeding and rapidly transport the patient, treating for shock as needed. Now, specifically for splinting, we want to check distal CMS, circulation, motor function, and sensation before splinting, and we need to document. Hey, patient, can you feel me tapping on your toes? Can you wiggle your toes? Document it. If you don't write it down, it didn't happen. Manually stabilize the injury. That may be that the patient is guarding, for example, a broken wrist close to their body. It may be a second patroller helping you to stabilize that while you're getting ready to splint. Choose the appropriate splint for the injury, and then make sure that you size it. Always span the joint above and the joint below to ensure that it's properly immobilized. Now, for a long bone fracture, it's very simple. Size it on the uninjured side. If the injury is to the right leg, as shown in this slide, size the splint on the left side. You may have to shape a splint, like a SAM splint, to match the injured extremity. Pat it for comfort, especially considering transport, and then you can proceed. Position the splint. Make sure that you secure the splint appropriately, and that's security needs to ensure that it won't move during transport, and then reassess CMS. Make sure that the splinting is properly applied and, for example, not too tight as you secured it, and no sensation or circulation is compromised. Document that too. Now, sometimes putting that injured extremity into its normal position is going to be difficult. Maybe the fracture is open or severely angulated, or maybe it's a pediatric patient who will not let you move the injured limb. In that case, you may have to just immobilize it in place. You may have to improvise a little bit. Perhaps you have a malleable splint like a SAM splint, and you can do your best to just splint it as it is found and transport the patient. Do not attempt to reduce a fracture that's open. For example, if you have an open femur fracture, the bone ends may return below the skin with a traction splint, but typically in an open fracture, we'll splint it in place, bandage the wound to control bleeding, and make sure that our handoff report to EMS includes the fact that the fracture was open. If there's significant pain, we can apply cold packs, such as snow in a gallon-sized Ziploc bag. We don't want to do that directly. We want to make sure that the patient is transported as comfortably as possible, and we may reassess CMS again after transport in case things moved during that time. Always check CMS before splinting. Make sure that motor function and sensation are good before you begin your treatment. Select the splint, properly size it, pat it, and secure it. Remember, immobilize above and below the injury. Check CMS after splinting to ensure that no compromise occurred during your bandaging. For example, the splint isn't too tight, and then transport the patient.